a novel method for evaluation of the extent of per-oral endoscopic myotomy. Per-oral endoscopic myotomy has proven to be a viable therapeutic modality for the treatment of idiopathic achalasia. Similar to laparoscopic Heller myotomies, POEM failure is related to inadequate extension of the myotomy onto the stomach, resulting in an incomplete myotomy. The purpose of this video presentation is to provide a novel modality for evaluation of the distal extent of the myotomy under direct endoscopic visualization. Evaluating the extent of the myotomy has been performed by a variety of methods. During the course of dissection, the endoscopist assesses the adequacy of the myotomy by observing the orientation of muscular fibers as they transition onto the stomach and begin to decussate and deorganize. Additionally, indigo carmine dye has been placed within the POEM tunnel and subsequently observed intraluminally on retroflexion views. In our experience, this at times is adequate, but can result in incomplete myotomies and POEM failures. Objective evaluation has been used with the EndoFlip catheter to evaluate the extent of myotomy, but this catheter is not widely available to all institutions. After performing routine EGD, the endoscopic mucosal resection cap is placed over the end of the endoscope. The GE junction is measured, and a point is chosen on the anterior wall of the esophagus, approximately 12 centimeters proximal to the GE junction. Utilizing an endoscopic injection needle, the submucosal space was injected with indigo carmine dye. This is to help facilitate the mucosotomy and subsequent dissection. A mucosotomy is then created using a needle knife electrocautery. The mucosotomy is extended to a length of approximately 2 centimeters. This should facilitate introduction of the endoscopic mucosal resection cap and the endoscope. Entrance is facilitated by a combination of electrocautery and blunt dissection. Once an adequate mucosotomy has been performed, the endoscope and resection cap are tipped into the dissection plane. This should aerate the alveolar tissues, and further dissection is required utilizing electrocautery. The dissection is taken distally until the muscular fibers begin to decussate and disorganize. Adequate distance is also approximated by gross measurement of the distance in which the endoscope is advanced into the newly created submucosal tunnel. While leaving the first endoscope in position within the tunnel, a second, smaller pediatric endoscope is introduced into the esophagus and advanced past the mucosotomy and into the stomach. This should pass with relative ease. The stomach is insufflated and a retroflexion view is obtained of the previously dissected GE junction. The light of the pediatric scope is dimmed and the light of the dissecting scope is brightened. If the extent of the dissection is adequate, the light should be readily identified on the retroflexion view. Light pressure may be applied to the dissecting scope to further illustrate the completeness of the dissection. Once the extent of the dissection is confirmed to be appropriate, the stomach is desufflated and the pediatric scope is withdrawn. When the pediatric scope is withdrawn slowly and with careful examination of the lumen, the mucosal tunnel can be observed, as well as the dissecting scope, which is seen here entering the mucosotomy on the anterior portion of the esophagus. In this case, the POEM tunnel dissection was straightforward. The tunnel was created with ease and extended onto the anterior surface of the stomach. Illustrating this maneuver again, the dissection has obviously been taken well past the GE junction in this case. The dissecting scope light is brightened and the extent of the POEM tunnel is further confirmed. With this, the stomach is desufflated and the pediatric scope is withdrawn. This confirmatory maneuver is performed with relative ease and in a rapid and straightforward manner. Finally, in this case, the poem tunnel dissection was noted to be difficult, secondary to previous endoscopic Botox injections. The pediatric endoscope was introduced into the esophagus and stomach. The dissecting scope light is observed in the distal esophagus while the pediatric scope is passed. The endoscopic dissection light was not originally observed within the gastric lumen. The pediatric scope was withdrawn, and further tunnel dissection was undertaken. On repeat intraluminal retroflexion, the end of the dissecting scope is now observed within the gastric lumen. The pediatric endoscope light is dimmed and the dissecting scope light brightened. The tip of the dissecting scope is now easily identified, and the extent of the dissection is confirmed. Now complete, the air within the stomach is removed, and the pediatric endoscope is withdrawn. During removal, the light of the dissecting endoscope is observed at the GE junction and traversed several times on repeat back and forth endoscopic motion. This method can be completed rapidly and provides excellent visualization of the distal extent of the poem tunnel dissection. This maneuver can be performed with little to no added cost and with instrumentation already owned, mitigating the need to purchase additional equipment.